Well, good morning everybody. We're here on the Friday morning of PVI at the beautiful Carousel du Louvre. I'm here with Makis Avgerinos from the University of Athens, and he's a specialist in treating acute pulmonary embolism. Welcome, Makis.
Welcome, Jorinde.
Can you tell us about, there's quite a lot of devices on the market. Which devices are available and which would you prefer and use in the treatment of acute pulmonary embolism?
Right. For the past 5 or 6 years, we've seen an explosion in the management of pulmonary embolism with endovascular interventions. Right now in the European market, I believe we have 3 systems available for the management of these patients. We have the ecosystem, ultrasound-assisted thrombolysis. These are generally small catheters, easy to navigate through the heart, low complication rate. The lytics still have the advantage that they can reach the remote branches of the pulmonary arteries that no other thrombectomy device can do that. However, lytics still have a risk of bleeding complications, and they need time to act. So for a patient that you really want to rush and prevent decompensation, waiting for 6 to 8 hours may not be appropriate. And this is where the thrombectomy devices are coming in. And I don't think one size fits all. Right now we have 2 thrombectomy devices available in the European market. We have the Penumbra CAT12 intelligent aspiration. It's a moderate size catheter, 12 French, again relatively easy to navigate through the heart, and with continuous aspiration and intelligent aspiration at the same time, you can reduce blood loss and you can get good results. Now finally, and it's my favorite, it's the FlowTriever device. It's probably the biggest catheter right now available in the market. It's 24 French device, and not everyone feels comfortable navigating a 24 French system through the heart. Still, when you use it and after you do a few cases, you will realize how flexible it is. And the fact that it is so big, you can efficiently remove a significant amount of thrombus. Eventually, I think that it's not necessarily the device that makes the difference in the outcome. It's the expertise of the center and it's management of the patient within the confines of a pulmonary embolism response team.
I think the results are really good. What kind of evidence do we need to consider endovascular as a first line of treatment for pulmonary embolism?
So for the past 2 years, we have been seeing a lot of trials coming out, but they are mainly industry trials, single-arm trials, without any comparative arm. Right now we have 2 randomized trials coming from industry, the HI-PEITHO, comparing ultrasound-assisted thrombolysis against anticoagulation for intermediate high-risk pulmonary embolism, and we have the INARI trial, the PEERLESS II, comparing the FlowTriever thrombectomy against anticoagulation, again for intermediate high-risk patients. But somebody can argue these are industry trials. The trial that we are eagerly waiting for is the PE-TRACT trial, NIH-sponsored, independent from industry, again comparing anticoagulation against any catheter intervention. I think the results are going to be available in a few years from now, and then we can definitely say that these procedures can actually help our patients.
Great. We were waiting for that. Thank you very much.